Hey guys, in this video, I'm going to talk about my thoughts on cholesterol or blood lipid testing and talk about what your doctor doesn't understand when they measure these things in your blood. So, since cholesterol was wrongly blamed for heart disease back in the 1950s and 60s, we've been using this lipid blood testing, this cholesterol blood testing, as the main tool to assess for cardiovascular risk. But what does measuring the lipids really tell us, right? Most doctors are just trained, you measure this lipid panel, and based on that panel, you give medications. But it's much less straightforward than that, right? So it turns out there's new research that's showing that what your total cholesterol or LDL are in the blood only really reflects what fuel source your body is using at the time. So, for example, if my body is using carbohydrates and burning more glucose, then my lipid levels will go down because the body that first burns glucose. So if you're burning glucose, you don't need as many fatty acids delivered to the tissues. And so LDL molecules are what carry fatty acids around and deliver them to the tissue. So if you have carbohydrates present, you don't need as many LDL molecules. But if you restrict your carbohydrates and you don't eat any carbohydrates, your body only has one fuel source to burn, those fatty acids, or it can make those fatty acids into ketones. And so it has to deliver more fatty acids to the tissues, so it packages them up into LDL and delivers them to tissues, so we get more LDLs in the blood. This has been something called the lipid energy model that's been published here. And so really what your metabolism or what your lipids are really just reflects what your metabolism is, right? If you're burning more carbohydrates for fuel, your LDL will go down. And if you're burning more fats for fuel, your LDL may go up because your body has to deliver more fats to the tissues. Um, and this was shown very eloquently in a case study. Well, it was shown by Dave Feldman in his white bread experiment, if you want to look that up. But it was shown in this published case study by Nick Norwitz, where he goes on a low carb diet. And so when he goes low carb, his body needs to deliver more fats to the tissues, so his LDL goes way up. And then he did that for a while, and then he decided to eat 12 Oreo cookies a day, and his LDL plummeted by like 71% or something like that. So basically he gave his body carbohydrates for fuel and it burned the carbohydrates instead, didn't need to deliver as many fats to the tissues and the LDL came down. And then he went off his low carb or went off the Oreos, went back on his low carb diet and his LDL went back up because he's changing his metabolism, right? So that's really what the cholesterol and LDL, that's pretty much what we can get from that right there. Is that now there are people who are metabolically unhealthy, overweight, diabetic, that type of stuff, and they go on low carb diets and they don't see this effect on their LDL. Like they go on low carb and it doesn't make the LDL go up. However, it seems that when they become metabolically healthy, once they become metabolically healthy through eating that diet, then after that happens, then the LDL goes up. So this seems to happen in metabolically healthy people. So the term is that they're lean mass hyperresponders, right? Once they're lean mass metabolically healthy, then their body will hyper respond with this LDL response. But it doesn't seem to have any reflection on cardiometabolic risk, right? So this always happens in the context of very low cardiometabolic risk because these people are metabolically healthy, and that's what really matters, not the LDL level. So now, the other thing that's on a standard lipid panel is the triglycerides, right? So if someone develops poor metabolic health by having disrupted circadian rhythm, their light environment is disrupted, or eating, in addition to eating a processed food diet, then they can become insulin or leptin resistant. And in this case, what's often the case in these people is that their triglyceride levels, their fasting triglyceride levels will be elevated. So this is one indication that there's poor metabolic health. If on a fasting blood panel, their triglycerides are, above 100 really, but if above 150, it's really bad. So that triglyceride to HDL ratio is something that can give us an indication of poor metabolic health. So on a standard lipid panel, which includes total cholesterol, LDL, HDL, and triglycerides, it can only really tell us two things. One, it can give us a sense of what we're metabolizing, either fats or glucose, based on what the LDL and total cholesterol levels are, or it can give us an indication of if we have poor metabolic health when we have triglycerides that are high, or a triglyceride to HDL ratio that's higher than 1.5. So that's pretty much all the standard lipid panel can tell us. It can't tell you you're going to have heart disease, or it doesn't really predict the risk of heart disease. It just tells us kind of about metabolism and what we're choosing to metabolize and metabolic health. Now lately, lots of people have been talking about different subfractions of LDL. right? And to me, this is like it's the industry saying, okay, well, we were wrong. It wasn't the LDL, but it's the ApoB, it's the oxidized LDL, it's the LP little a. It's the particle size and number, all that stuff. They're trying to find all these subfractions to still blame the lipids, when in reality, the answer to heart disease is not going to come from the lipids, in my opinion. But let's talk about some of these things. So ApoB. So a certain percentage of your LDL molecules are of the ApoB variety, right? So if your LDL goes up, by default, the amount of ApoB can also go up because a certain percentage of those LDLs are ApoB, so it's going to go up. But in the context of metabolic health, this does not mean increased risk. Just like elevated LDL in the context of metabolic health doesn't mean increased risk, ApoB is the same way. Now, ApoB, it seems, can also become elevated when we are in a state of poor metabolic health. So ApoB is not the problem. The poor metabolic health is the problem, right? And so there's studies out there that will show, oh, elevated ApoB is associated with higher rates of heart disease. But it's not the ApoB that's creating the higher risk, it's the poor metabolic health. And sometimes people with poor metabolic health can get higher ApoB. And so this means that trying to lower your ApoB with a statin drug or lower your LDL with a statin drug does nothing to help you prevent heart disease because it's just artificially lowering that number. It's not fixing the cause, which is the metabolic health. Matter of fact, lowering your LDL and ApoB with a statin drug has actually been shown to decrease metabolic health and create poor metabolic health. Statin drugs have been shown to do that, increase the risk of developing insulin resistance and diabetes. So it's very backwards here. We can't just look at a number and say, oh, if we get this number where it's supposed to be, then we're healthy and we're protected. No, because the number is just a reflection of what's happening in the body. We have to fix the thing that's happening in the body. So that's ApoB. Now, let's talk about oxidized LDL. So, or small dense particles, particle size, those types of things. So when our LDLs get damaged, because we have low body charge, so lack of electrons in the body, which people will call inflammation or oxidative stress. All that really means is you have low body charge. Or when we have poor metabolic health, this means that some of your LDL molecules can get damaged. They become oxidized, right? So we call this oxidized LDL. But it's not the oxidized LDL or the small particles that are the problem. It's the things causing the low charge, the inflammation, which are toxin exposures, lack of sunlight, lack of grounding, and the poor metabolic health, which comes from a processed food diet or disrupted circadian rhythm. Those things are the problem. So we have these studies that show, oh, high amounts of oxidized LDL are associated with higher risk of heart disease, but it's not the oxidized LDL, right? It's the things causing the oxidized LDL. It's the inflammation. It's the disrupted circadian rhythm. It's the poor metabolic health. Those are the things that are increasing the risk. And so if we take a statin to lower the oxidized LDL, it's like, okay, that's great, but we still have all these other things that are happening that we didn't address, which is why that's not going to help. So the things that are damaging the lipids are also damaging the artery wall, causing the risk of plaque development. So lowering the LDL numbers with a drug is doing nothing to fix those issues. So again, it's kind of this proxy of what the state of the body is. But, oxidized LDL could technically contribute to that damage because it's a damaged molecule too, but it's not the oxidized LDL. It's the things that are causing that. Okay, so now LP little a. So LP little a is a form of a lipoprotein with the little A protein attached to it. And what this molecule's job is to do is to prevent the breakdown of clotting tissue. So if you look at what plaque is, it's clotting tissue. It's like a large percentage of it is fibrotic clotting tissue, the same tissue that if I cut my skin, a scab forms, right? So if I have high levels of LP little a, which this is said to be somewhat genetically predisposed, we're predisposed with this number. We can't really do much about it, supposedly. However, if we get this high number and then we get damage and we get clotting tissue that forms, LP little a's job is to prevent the breakdown of that clotting tissue, which means that when that clotting tissue forms, which is this plaque in the artery wall, our body has, it tends to stick around more if we have higher LP little a, because the LP little a is preventing the breakdown of clotting. So it has a very specific job, because when the body is trying to initiate clotting tissue non-pathologically, we need that to stay around. Your body's doing that for a reason. That's LP little a's job, is to do that. But the answer here is, if you have genetically high LP little a, it's not to lower that LP little a or put all our focuses on lowering that with a statin or whatever, trying to lower the amount of lipoproteins to lower LP little a, because that's doing nothing to prevent clotting, right? The real issue is not having clotting responses, pathologic clotting responses. Physiologic clotting responses are normal. They're necessary. We need those. But if we have pathologic clotting responses and we have high Lp(a), that's the recipe for plaque that sticks around for a long time. But if we do things to prevent the damage to the artery and stop the clotting response from happening, then the Lp(a) is irrelevant. It doesn't. It's not. There's nothing to help prevent the breakdown of if we prevent that from happening. And so, preventing the clotting response is about preventing damage to the lining of the artery, keeping blood moving properly, and keeping the blood thin and less viscous from a biophysics perspective, which I've talked about in other videos. So let's kind of summarize that. And this is the most important thing I'll say in this is while our lipids they can indirectly tell us some things about heart disease risk, like if there's inflammation or if there's poor metabolic health, things like that. Our risk has little to do with the lipids themselves, right? It has more to do with the imbalances in the body reflected in the lipid testing. So this explains why treating lipids with drugs and like treating the actual numbers and trying to make your numbers look a certain way is not helpful for preventing heart disease. And pharmaceutically lowering lipids does nothing to correct the imbalances that are causing the heart disease, right? And sometimes, those pharmaceutical agents are making things lower. There's more risk of metabolic health and poor metabolic health and taking a statin. So yeah, I hope that makes sense. And it's a very, very important distinction to make is that the lipids themselves are not what's causing risk of heart disease. It's what their lipids are reflecting as far as the physiology of our body that are really increasing the risk. So, and then last thing I want to note is that concerning lipids, I've talked about this in other videos too, more extensively, but there is a cell-free layer of exclusion zone structured gel-like water that lines the arteries. People have called the glycocalyx this gel-like anticoagulant layer. But what makes it a gel layer is that the water in the blood can become structured gel-like water on the lining of the artery on this glycocalyx. So this has been proven. You can see this image here. They show this gel-like easy layer. They've shown this in Dr. Pollack's lab, but if you just type in PubMed cell-free layer, all kinds of research comes out from many different research groups that show that there's this cell-free layer that protects the lining of the artery. So this gel-like water is one of its properties is that it excludes things that aren't it. So only very small hydrated ions of minerals can penetrate this. So red blood cells can't, lipoproteins can't, even HDL, the smallest lipoprotein, can't penetrate structured water. So if we have that structured water there, what your lipids are in the blood is never going to touch the lining of the artery, which this whole theory is that the lipids are damaging or they stick to the lining of the artery, but that's never going to happen if we have this structured water there. And so this means if we do things to keep the gel-like layer healthy, no cholesterol or blood lipid can ever touch the artery wall, which this discovery in itself suggests the entire lipid hypothesis is pretty much wrong. There has to be something that happens first to this structured layer wall for lipids to become relevant in a process of healing and everything like that. But that doesn't happen. The lipids aren't touching the wall whatsoever. So it kind of throws the whole lipid hypothesis on its head. And again, I've talked much more about structured water in some of my lectures and other videos and things. So you can find that there. So, but considering that, one of the best ways to protect our arteries is build the structured water, would be important to know what builds that structured water. And the number one thing that helps build that structured water is infrared light, because infrared light from the sun is the most effective light source that our body can use for energy. So it stores energy, and that energy is stored as structured water. So when you get infrared light, it builds structured water. And there's research that shows this. And why does this make sense? It makes sense because anytime the sun is up, it's 40 to 50% infrared light. So all life on this planet is supposed to be outside in this infrared light all day long. Even when you're sitting in the shade, the infrared is reflecting off things and hitting you. But we're living indoors. So considering that our modern way of life keeps us indoors and away from the best source of infrared, which is the sun, I think this is a major contributor to why we have an epidemic of plaque in our arteries. We're removing the thing that's protecting our arteries. And there's many other aspects of that as well. So, I mean, the research shows that the average person today in the modern world spends about 93% of their time either indoors or in an enclosed vehicle in environments that are void of infrared light because the indoor lighting doesn't have it. So yeah, so that's what I have to say about lipids. Hopefully that made sense and cleared some things up for you. And hopefully it gets you to thinking that your environment is much more important than what your numbers on a panel are, right? So what's your light environment like? What's your diet like? All those types of things are dictating metabolic health and structured water, all that kind of stuff. That's much more important than knowing what these numbers are and making them look a certain way. So yeah, these are things that I teach people in my 12-week heart health mentorship program. So if you want to learn more about what the actual causes of heart disease are and how to prevent it in this program and work with me directly, then click the link in the description of this video to set up a call so we can talk about what working with me looks like in my 12-week heart health mentorship program, so we can see if it's a good fit. So hope you enjoyed the video. Stay healthy out there.